This is an article presentation for EDP 520, and the article I have chosen to present is about the outcomes of prolonged exposure therapy for veterans with post-traumatic stress disorder. And the authors of the article are listed below its title, as well as my own name. I am Charlotte Haigh, and I will be presenting this article, which was originally published in 2013. So the article starts off with an introduction that includes some more information about veterans, the VA, and post-traumatic stress disorder. Post-traumatic stress disorder, or PTSD, is a chronic and disabling condition that is common among military veterans. As of 2009, an estimated 19 to 21% of treatment-seeking veterans of Operation Enduring Freedom and Operation Iraqi Freedom reported symptoms of PTSD. Lifetime prevalence rates of PTSD are approximately 12% among Gulf War veterans and 30% among Vietnam War veterans. The U.S. Department of Veteran Affairs, or the VA, is responsible for providing effective treatment for veterans with PTSD. In 2010, the VA provided health care for 8.3 million veterans. That number is on the rise, and it's expected to keep increasing. As more veterans seek mental health treatment from the VA, it's important to identify evidence-based treatment methods to help veterans who suffer from PTSD. Prolonged exposure, or PE, has been identified as an effective treatment of PTSD among veterans, and it's been adopted by the VA as a common therapeutic practice. So what is prolonged exposure? Prolonged exposure, or PE, is a form of therapy that's shown efficacy in treating PTSD primarily among civilian populations. However, the authors of this article note that initial studies evaluating the efficacy of PE with veterans suffering from PTSD have shown promising results as well. Initial VA data shows a 30% overall reduction in symptoms among veterans who complete PE, and those are symptoms of PTSD. In addition, a 2007 study using PE among female veterans and active duty service members demonstrated that PE was more effective than present-centered therapy at reducing PTSD symptoms. So PE works in the ways listed in the second half of this slide. So there's core interventions, including psychoeducation, breathing training, imaginal exposure, and in vivo exposure. The therapist works with the client to revisit traumatic situations through in-session narration, which is the imaginal exposure component, and then also through real-life situations, which is known as in vivo exposure. It's typically delivered over 9 to 12 weekly or twice weekly 90-minute sessions, and clients gradually build up to processing more distressing traumatic memories and eventually become habituated to the anxiety and fear that is provoked by revisiting those memories. The focus of this study was to build upon the preliminary findings that PE is an effective form of treatment for veterans suffering from PTSD. And the researchers introduced PE to a wide variety of veterans suffering from PTSD who seek treatment at various VA outpatient clinics. The study's main hypothesis was that veterans who completed PE would show significant improvements on self-report measures of PTSD, depression, and quality of life. Because combined treatment, which is pharmacology or medication and psychotherapy, is a popular method of PTSD treatment in VA clinics, the study also focused on examining the effects of psychiatric medications on PE response among veteran participants. Other factors that were considered included the trauma category, service connection status, chronic pain diagnoses, and the practicing clinician's level of familiarity with PE through VA training initiatives. I'm going to focus, just for the purpose of simplicity, on the third and fourth bullets about improvements on self-report measures of PTSD, depression, and quality of life, as well as the difference in a combined treatment method of pharmacology and psychotherapy when it's compared to simply doing prolonged exposure or psychotherapy. So the method of this study, this was a naturalistic study that evaluated the effectiveness of PE for treating PTSD at an urban VA medical center as well as the surrounding community-based outpatient clinics. And the participant base was made up of 115 veterans who had been diagnosed with PTSD and were actively receiving PE in outpatient clinics. So the different places that they found their participants include the PTSD clinical team, the general mental health clinic, community-based outpatient clinics, the addictions recovery unit, primary care mental health, the opioid treatment program, and the polytrauma unit. Participants completed self-report measures of PTSD, depression, and quality of life pre- and post-treatment. The different measures that were used are listed here. So PTSD symptoms were measured using the PTSD checklist military version, or the PCLM. And that's a 17-item self-report measure designed to assess the severity of PTSD symptoms. And it's shown good internal reliability. And the higher the score on the PCLM, the more significant the PTSD is considered to be among veterans, with a score of above 50 being considered pretty significant. Depression symptoms were measured using the Patient Health Questionnaire 9, or the PHQ-9, and that's a 9-item self-report measure that's designed to assess symptoms of depression. This measure has also demonstrated strong internal consistency, and individual answers are scored on a 4-point Likert scale, with the higher holistic score indicating a greater level of depression. Quality of life was measured using the Behavioral Health Questionnaire 20, or the BHQ-20. And that's a 20-item measure that assesses global mental health. Again, this has been shown to be reliable and valid with adequate internal consistency, test-retest reliability, and construct validity. Data regarding the other factors that were looked at, including a patient's prescriptions to psychiatric medication or their reports of chronic pain, were taken from his or her own medical records, which were provided by the VA. And the procedure, so 25 PE-trained therapists conducted sessions with veteran participants who had already been diagnosed with PTSD, and at least 8 sessions were completed per patient in order for the results to be included. So patients were given the depression, PTSD, and quality of life assessment measures pre- and post-treatment in order to assess for improvement among these 3 conditions. And here are the results and participant demographics. So 84 of the original 115 veterans completed the treatment, so 8 or more sessions. 34 veterans did drop out of this study over the course of treatment. And the mean age of the sample was 51 years old, and 86% were men. Participants who completed PE treatment saw an average decrease of 19 points on the PCLM, which indicates a 41% reduction in PTSD symptoms. And that corresponds to a Cohen's D effect size of 1.45. In terms of depression, participants who completed the treatment saw a reduction of approximately 4.9 points on average when compared to pretest scores on the PHQ-9, and this corresponds to an effect size of 0.90. Participants also saw improvement in quality of life, with post-treatment scores in well-being and life functioning improving, with effect sizes of 0.8 and 0.90 respectively. Interestingly, veterans who were not taking medication reported greater pre- to post-treatment PTSD symptom reduction than those who took medication. So people who received prolonged exposure without medication actually reported greater symptom reduction, which is very interesting. So the discussion, there's sort of a few key points. The first key point is that PE is effective in reducing veterans' symptoms of PTSD and depression, as well as improving their overall quality of life. And the 2 points below, or the 1 point below, really calls that out about the different meaningful decreases across PTSD, depression, and then increases in well-being and life functioning. It should be noted, too, that participants who dropped out of the study were likely to be younger, which is consistent with previous research. The younger dropout age may indicate a struggle to balance pressures of family, work, or school, and other areas that demand the focus of younger adults. And some limitations that the authors laid out, the researchers would have perhaps benefited from a larger sample size. They had a 27% dropout rate, which brings up greater questions of therapy attrition among veterans. In addition, this was a naturalistic study, so that offers good generalizable knowledge about the benefits of treatment in a real-world setting, but it doesn't offer the same amount of control or detail that could be attained through randomized controlled treatment outcome trials. So future studies would also benefit from following up with participants to assess long-term maintenance and treatment gains for completers of PE, which the authors did not do in this study. So that's the critique of this article, and here is the reference in case you want to check out the article. And thank you so much for your time. Have a good one.